Session is my worst nightmare, complications in intervention. Moderator for this session is Dr. M. Rayhan Masum Mondal.
আমার সাথে আছে আমার বড় ভাই ডক্টর কলিমুল্লাহ ফর মডারেশন স্যার। এই সেশনের চেয়ারপারসন হিসেবে আমি আমন্ত্রণ যাচ্ছি প্রফেসর কামরুল ইসলাম স্যারকে, প্রফেসর সৈয়দ আলী হাসান স্যারকে। প্রফেসর সৈয়দ আলী হাসান ফোন করেছিলেন, উনি একটু শারীরিকভাবে অসুস্থ। প্রফেসর আতাহার আলী স্যার, প্রফেসর মীর জামাল স্যার। আর প্যানেলিস্ট হিসাবে আমি আমন্ত্রণ যাচ্ছি প্রফেসর ধীমান বানিক স্যারকে, ডক্টর S.M কামরুল হক, ডক্টর হরিপদ সরকার, ডক্টর মুস্তাসিরুল হক।
আমাদের স্পিকাররা আছেন প্রফেসর D.S গম্ভীর, ডক্টর মনির হোসেন খান, ডক্টর টুনাজিদ আফরিন খান and ডক্টর ইসমতারা.
Now I am requesting Dr. Monir Hossain Khan for presenting his case. It is an RCA dissection with the retrograde extension to A. Dr. Monir Hossain Khan, he is working as an assistant professor in our National Institute of Cardiovascular Diseases, and he is a good and one of the promising interventional cardiologist. Let's see his case.
Honorable Chairperson, Moderators, Panelists, Assalamu alaikum and good afternoon. My topic is nightmare following PCI to RCA CTO. Particulars of the patient. Mr. Hassan Mahmood, 30 years old, hypertensive and dyslipidemic, admitted into NICPD with unstable angina with old MI inferior. Blood sugar, serum creatinine, hemoglobin percentage, chest X-ray, posterior anterior view were normal. Echocardiography showed inferior wall hypokinesia with 50% ejection fraction. This is the basic angiographic view of the left and right system, showing RCA proximal occlusion, and in the mid panel we see retrograde filling from mid and proximal panel. We see retrograde filling of RCA from the left side. So we decide to open the RCA CTO and take a Zutkin right catheter and place into right coronary ostium, and pilot 150 wire passed beyond the lesion. Then we check the right coronary artery and we see the flowing picture. And the current status of the patient was minimal chest pain but hemodynamically stable, and ECG change were normal. Treatment option: conservative treatment, that is wait and see, immediate stenting to the entry point of dissection, or surgical management. Likely 50% stenting and 20% conservative treatment solve the problem. Systemic literature review provided 107 published cases of aortocoronary dissection during PCI that occurred mainly in the right coronary artery, 74.8%, and were treated with stenting 49.5%, and emergency CABG 29% or conservatively 21.5%. Shark et al. Proposed emergency surgery for aortocoronary dissection is not needed in the vast majority of cases and should only be recommended for the following two clinical scenarios. Number one, occlusion of the dissected vessel with cessation of the integrate flow that cannot be restored percutaneously, and extension of the dissection to the descending aorta. So we proceed to immediate sealing of the presumed site of entry door for aortocoronary dissection by percutaneous stenting as a bailout procedure. At the last panel, we deployed the stent, and no new extension of the no new retrograde area of the dissection we seen. So we proceed to treat the distal lesion, and we predilate and put the second stent, and final result was like that. And at last we do the check aortogram, and no dissection was confined to beyond the origin of the innominate artery. We had seen the picture. Patient was stable, and we kept him into CCO. In after 1 week, we did the CT angio of the aortogram, and we find that hypodense area in ascending aorta is measuring about 52 millimeter into the ascending aorta. But patient was stable, and we discharged him and advised him to come to us for follow-up after 1 month. It is this discussion in short. It is rare, but potentially incidence is at 0.2 to 0.8 during diagnostic procedure, and 0.7% during PCI. The entry point is usually caused by direct trauma, either catheter trip, forceful balloon inflation, dilation of the calcified plug, aggressive manipulation of the rigid of hydrophilic guide wire, non-coaxial position of the catheter, vigorous contrast injection with a wedged catheter. Based upon the extension of the involvement of according to the Daniel et al. Class 1 involvement only coronary cusp, class 2 extension of the aortic wall up to 40 millimeter, and 3 is beyond 40 millimeter. Class N and class 2 dissection were managed successfully by wait and see or performing PCI, and in contrast, class 3 dissection necessitates immediate surgical intervention and associated with higher mortality. This is the figure of the Daniel classification et al. Indication of surgery: progression of aortic dissection with hemodynamic instability, acute aortic regurgitation and hemopericardium, intractable chest pain, and type 3 lesion. Life-threatening situation like hemopericardium, chest pain, occlusion of the contralateral coronary ostium, occlusion of the aortic arch branches. Take-home message: awareness is the best form of prevention. Cautious, judicious, and technical use of guide wire contrast medium, early recognition, stoppage of contrast injection, quick assessment, and immediate decision is life-saving. Heparin antidote, inotrope, venous access for TPM, defibrillator are always should keep near to hand. Conservative management is still a reasonable point. Localized dissection and stable patient in vast majority in osteolation, sealing of the entry site by PCI is preferred as well as bail-out procedure, and some cases needed surgical back out. Thank you, and thank you all for patient hearing.
Thank you, Dr. Monir Hussain Khan, for your nice demonstration of your complication. But now I request Dr. Tunajina Afrin Khan for his case presentation. She will talk along a narrow, bumpy road with a sweet, tweety bird. And in the meantime, Dr. Dhiman Banik, I request Dhiman Banik sir to few comments on presentation of Dr. Monir Hussain Khan.
Doctor, not for discussion only. What was the wire? What was the wire? Wire ta ki?
Pilot 150.
Pilot 150. You can't go with a pilot 50 at the first. You should go to a run-through wire. Pilot 50 is a hard hydrophilic wire. That caused the dissection from the ostia. And what time did you take after seeing the dissection in extending into the aorta?
At the first injection.
First injection. Then how many minutes you take to put a stent? কতক্ষণ চিন্তা করছো যে আমি স্ট্যান্ড দিব কিনা, ঠিক আছে কিনা, আবার ডাই দিছো কিনা?
When we see the retrograde extension and patient complain chest pain to some extent, then we decided immediate.
তোমাকে you should decide it immediately. The dissection, there is dissection extending to the no time. And you, I think so. To me, the stent should be more proximal, covering whole one or two stars should be in the aortic root.
Yes, sir.
And I think so. The then maximum time the dissection is covered.
Yes, sir.
Then I think so. 1 or 2 millimeter area is left, and the dissection extend into the aorta.
I want to ask one thing.
Thank you, sir.
You checked arch of the aortogram you did.
Yes.
What catheter was it?
Pictal, sir.
It was not pictal. It was not a pictal. Was it hand injection or a power injector?
It is not a pictal.
It was not a
It
pictal.
should be pictal.
So remember, if you go other than pictal for aortogram, never use power injector. That may cause another dissection.
Thank you.
Thank you, sir. Dr. Tunajina, ready?
Assalamu alaikum. Good evening. I'm Dr. Tunajina Afrin Khan from United Hospital, and I'm going to present my case here. My patient was a 73-year-old gentleman, hypertensive diabetic, who presented with us with a diagnosis of non-STMI. Echo revealed apical zone hypokinesia with LV ejection fraction of 55%. Biochemical parameters were within normal limit, and coronary angiogram was done on 25th February in this year. This is his coronary angiogram showing codominant LCX with significant lesion in distal LCX and very big, the ostial part of the very big OM, and also significant lesion at the proximal LED, and calcification is also seen from proximal to mid LED. Here we can see the codominant LCX here. There is also a big diagonal with an early origin from the LED, which was also moderately diseased at the proximal part and severely diseased at its mid part. RC was normal. So the issues were, we had an calcified LED, big diagonal, which was moderate to severely diseased, codominant LCX to OM lesion. So should we go for CABG or PCI? So we did the synthetase score, which showed the equal result for CABG or PCI. But EURA score showed high mortality for CABG. So we discussed the issues with the patient's party, and they opted for PCI. And we also had to deal with some issue while doing PCI in LED, because distally the LED was diffusely diseased. So probably the patency for the graft will not be good here if the CVG was done. So if it was a calcified LED, so we needed to do either rota or intravascular lithotripsy. The big diagonal negotiation only it was pinched if we do the PCI in the LED. For LCX, we decided to do PCI to LCX to OM, and we also decided to do pre and post procedure IVUS. We took EBU 3.06 French guide catheter, and we took run through floppy wear. We faced some difficulty to negotiate our wear into OM. Then we took the crusade, and we took another run through floppy, one through wear, and we passed to distal LCX one wear, and another where we could negotiate into the distal OM. We first pre-dilated it with 1.5 into 15 balloon. And gradually it was pre-dilated with a 2 into 15 and 2 into 20 millimeter balloon. But we needed to do repeated pre-dilatation, because after the first pre-dilatation we faced difficulty to negotiate the stent, as it was a very tortuous vessel, and we vigorously pre-dilated it. Still we faced difficulty to negotiate our stent. Then we took a body wear, and after that we could negotiate the stent. It was a 2.5 into 24 millimeter drug-eluting stent, and we successfully stented the lesion. Then we took the same wear and we wear the LED, and we did the first IVUS. This is the most concentric part, the proximal part of the LED, proximal to the D2. This is the proximal LED, and then L6 is coming in view, and left main. So we also did another run of the IVUS to decide whether we should intervene the diagonal one. But after doing that, we could see the ostium of the diagonal one was having a good diameter. So we didn't went for 2 vessel PCI in this case in LED. So we decided to do IVL in this case. So it was a 3 into 12 millimeter intravascular lithotripsy balloon, and we did the IVL balloon pre-dilatation approximately with a 60 pulses. But we didn't do it at the same time. We took a few minutes interval before doing this balloon dilatation or intravascular lithotripsy. Then we negotiated the stent with 3 into 24 millimeter drug-eluting stent. Then we post-dilated. It was the post-stenting IVUS. And after doing the post-stenting IVUS, we could see some malapposition, and we post-dilated further. So my take-home message is intravascular lithotripsy is a safe and effective method for calcified lesion treatment, and intravascular imaging is mandatory to qualify the need and optimization of treatment with IVL, and to negotiate intracoronary balloon or stent in a tortuous vessel, body wire support helps. So thank you all, and I recognize my teacher Dr. Afzalur Rahman sir in regard of this case, who had the confidence to let me proceed with this complicated case. Thank you all.
Thank you, Dr. Tunadjina, for your presentation. Now I request Dr. Ismotara Ismotara to present anterograde LED CTO PCI after opening of the RCA CTO where there were wire on visible septal collateral connections. In the meantime, I request Dr. S.M Quamrul Huq sir to say a few comments on presentation of Dr. Tunaddin Afrin Khan.
Thank you, Dr. Tunaddin Afrin Khan, for presenting a nice case. Every case is a challenging case and a testing to interventional cardiologist. From every case we learn, from every mistake we learn and update ourselves. Thank you for presenting a nice case and handling the case very beautifully. And I convey my sincere thanks and congratulate you for presenting the case. Thank you.
Thank you, sir. From audience, if you don't have any question, so Tunajina can leave.
Assalamu alaikum, respected chairperson, moderator, panelist and all participants. I am going to present a CD about antegrade LED CTO PCI after opening of RCA CTO where there was no visible septal collateral connections. Our patient was a 61-year-old gentleman presented with history of crescendo angina over couple of months. He was smoker and hypertensive. He had history of several times hospitalization but never evaluated invasively. His LV ejection fraction was 45%. Baseline angiography shows LED CTO at the proximal part with retrograde filling from the conal branch of RCA. There was another CTO at the mid part of RCA, retrograde filling of distal part from the left side. Ramus intermedius was good sized, having 90% stenosis at its proximal part. LAO caudal view shows LED totally occluded at the proximal part, no ipsilateral filling. Ramus intermedius has 90% stenosis at its proximal part. RCA was early divided and the major branch is totally occluded at the mid part, conal branch filling LED. LAO cranial view shows occluded RCA branches retrogradely filled from the LCX. Patient was advised immediately for CABG but he denied. Then he was put on maximum medical therapy and detailed discussion was made about the possibility and outcome of the PCI with the patient and his relatives, but patient decided to undergo PCI. There was some complexity about LED CTO as its length was 20 mm, side branch at the proximal cap, distal cap was convex, there was some calcification and there was no appropriate interventional collateral. So according to hybrid algorithm, antegrade OIR escalation strategy was taken and PCI was started with RCA. With the help of microcatheter and pilot 50 OIR was crossed the occlusion. Balloon dilatation was done with 1.25 mm and then 2.5 mm. A drug-eluting state of 3x40 was deployed in the RCA with good TB3 distal flow. Then LED CTO to ensure better collateral visualization of post-CTO portion of LED, a microcatheter was parked in the conal branch and antegrade OIR escalation started. Using OIR Conquest Pro 12, managed to get through the occlusion in the LED. Distal cap was punctured and was confirmed by retrograde injection. Then OIR exchange for round-through OIR was done. Then gradual balloon dilatation was done to LED. After balloon dilatation of ramus intermedius, a drug-eluting stent of 3x40 was deployed in LED. Post-dilatation with 3.5 NC balloon. OIR exchange to ramus intermedius, another drug-eluting stent of 2.5x18 was deployed in ramus intermedius. Then tap and kissing balloon inflation was done to ensure optimal stenting. Post-dilatation of LED was done and this is the final result. Whole procedure took 220 ml contrast volume with fluoroscopic time 58 minutes and radiation dose was 3.6 gray unit. Antegrade OIR escalation is the best strategy for CTO opening in most of the cases. Collateral connections from opposite side, if seen by contralateral injection, the job becomes easier. When no collaterals apparently available, then search for other sources. Above all, it is the proper planning that brings success to such a such a complex interventional case. I am grateful to Dr. Habibur Rahman, Associate Professor and Senior Consultant, Department of Cardiology, for giving me the opportunity to present this case. Thank you.
Thank you, Dr. Ismotara, for your nice presentation. Now I request Professor D.S. Gambhir sir to present his case.
Since the time given is too short, let me show you only the cases rather than having a detailed discussion on left main dissection management. Let us run through some of these slides. Well, despite all the pre and peri-procedural precautions, mishaps do occur. And this is one of those mishaps, complications of left main intervention. And dissection is the most lethal and serious complication. A rare incidence is low, and the course is very unpredictable depending upon how bad is the dissection. Causes are too many. Let me forget about these things right now. Now, we classify these dissections into two types, antegrade and retrograde. There are several classifications, but I think what is most important is a simplified classification of LMCA dissections. Type 1 is when it is localized dissection without extension into LAD and LCX. Type 2 is when LMCA dissection extends into LAD or LCX, and type 3 is dissection extending into the root of the aorta. Let me go on to the cases. First of all, this is the case number 1. This is a patient who had a left main trifurcation stenting. This is the pre-PCI left coronary angiogram. You can see here LAD, the two branches coming in between the circumflex and the LAD. One is possibly a ramus, the other is a obtuse marginal branch. And we did a SKS technique and jailed the guide wire of one of these branches. SKS technique was done successfully. And then we rewired this obtuse marginal branch through the struts of the LCX stent and stented the obtuse marginal branch. Now, following that, we did a triple balloon kissing using 2 guiding catheters from both the groins, and we thought the job has been done. But then when we looked at the result, there is a major dissection in the left main, possibly caused by triple balloon. You can see on the superior border. So this had to be confirmed by a IVUS done. So IVUS shows that the stent is well opposed, and there is a horseshoe-shaped dissection in the body of the left main, which was extending right up to the ostium of the left main. So obviously this needed to be sealed. So we deployed a DES in LMCA, a very short DES, I think it was 8 or 9 millimeter, into the left main, going into one of these struts, which was in the SKS technique. Having done that, this IVUS was repeated, and you see that the dissection has been totally sealed. So this is the final result, excellent result. Okay. Now, this is a very frightening case. This is a dissection which is extending into both the LAD and LCX branches. This is a totally normal left main, but we are doing a circumflex artery, which was subtotal occlusion. So I was very fond of using Amplas guiding in these cases. So we use Amplas, and I guess right from the beginning that we are heading into a problem. So you can see the tip of the guiding is lying right at the mouth of the left circumflex artery. And this was used obviously to get a support from the circumflex, from the guiding to go into the circumflex and get access to the distal part of the circumflex through the CTO. So once we had crossed this, the guide wire is in the PDA, and we did a balloon dilatation at the CTO site. We pulled the guiding out, and this is what we saw. There is a major dissection in the left main, and this is extending into the wall of the aorta with the dye leaking into the wall of the aorta. The patient became symptomatic at this point of time with severe chest pain, but there was no fall in blood pressure. Now, the point of interest here is I must pause for a second and tell you that never ever pull out the wire and the guiding catheter in a hush in this state. Because if you pull out the guiding catheter and the wire, then you would lose an access to this, and then you may catch a false lumen with another guiding catheter. So what we did was we withdrew this guiding catheter a little bit, and how we withdraw the guiding of a ampulas is that you push it a little bit. So it comes out of the left main, and then we partially withdrew this guiding catheter from the LMCA, as you can see here. And then we took another wire and we passed this wire, which took us a minute or two to get into the true lumen. And we had a wire already in the circumflex, so with this we wired the LED, and then we did a left main bifurcation stenting. You can see here that we first stented the circumflex at the CTO site, and then put a long stent in going from the left main into the LED, sealing the dissection. And this was the result after the bifurcation stenting. There is some small leak which is still there, but next day we got the CT angio done, and this was all sealed. So this is just the final kissing balloon dilatation and the angiogram final result. And then of course we completed some of the other distal vessels. Now the last and the most lethal dissection. This is a old lady about 78 years of age. She came with acute inferior wall MI, and we did her primary angioplasty, and so she was doing well. On day 3, she had some disease in the distal part of the LED, which is not seen here in the bend, some in the hair. So I don't know why we thought we should treat all these vessels. So as soon as we hooked the left main with the guiding catheter, and you can see here, the guiding tip hit the left main, and it caused a serious dissection which extended on to the circumflex. Well, we had not even wired at that time, so a lot of difficulty we could wire this circumflex, and we wanted to now implant a DES into the osteoproximal part of the circumflex. But the stent would not go. With a lot of difficulty we could manipulate the stent. Finally the stent got into the LCX, and we kept the proximal end of the stent right at the ostium of the circumflex. The stent was deployed, but somehow the stent did not open up completely. It did open up, but it did not possibly relieve the obstruction completely. So now we were trying to pass in a balloon to open up the stent further on, and passing the balloon led to hitting of this balloon, distal end of the balloon into the carina, and that led to the dissection extending from the circumflex ostium into the LED, and the whole LED started occluding. So we had to wire with this LED with a lot of difficulty. By this time the patient became hypotensive. I'll skip this step. So once the LED access was obtained, so we put multiple stents into the LED and sealed the dissection. Finally we put a long stent from LED backward into the left main, and this was the final result. So everything became all right, patient became normotensive. So the take-home message is that rapid action response is the key to success in these patients. Careful manipulation of catheter, balloons, stents and other devices is extremely useful in preventing mishaps and mortality due to left main dissections. Thank you.
Thank you, Gambhir sir. On behalf of all intervention cardiologists and all cardiologists of Bangladesh, we are grateful to you, sir. You have come from abroad and give us last 2 days time and shared with us your knowledge. So we are at the end of our session. Before ending the session and all of the session, I will request to Dr. Professor Qumrul Huq sir to say a few words.
Thanks, Professor Dr. D.S. Gambhir, for presenting his challenging case. For the last 2 days, he gives a lot of information regarding modern intervention techniques. And I also thanks all other speakers for their presenting cases. Due to short of time, we now ending this scientific session, that we have an important session after this session. So thanks again. Thank you all.